it doesn't give you the opportunity to really reach out and reach the masses as much as I think we need to. So I look forward today, for this session being an opportunity for us to talk about what dementia is, how it can present differently to different people, and then we'll sort of talk about the different types of dementia, things that we worry about along the way, and then we'll go from there, okay? So then at the end, we have some questions, and I'll be here after, as well. And if all the questions aren't answered prior to me, ending, then, I'll, connect with, Kim, Sharon, Jeannie to sort of make sure that whatever question you have, I'll be able to answer as much as possible, okay? All right.
Okay.
So I think the biggest elephant in the room, when I am going out and talking with people is, what is dementia and what is Alzheimer's and how are they different? So I think the first thing I like to discuss is the fact that dementia there are a lot of different types of dementia. And Alzheimer's is one type of dementia. So that's the biggest thing that often I like to discuss, because sometimes patients and families will say, Dr. Carrol, mom was diagnosed with dementia, but I just hope it isn't Alzheimer's, okay? There can be some truth to that. All forms of dementia don't have to be Alzheimer's, but in most cases, when a patient is told that they have dementia and it isn't really classified or further clarified, it's most likely that they have Alzheimer's. That's the most common form of dementia. So if we look at 10 people that have dementia, about 6 or 7 of them will have Alzheimer's. So the most common form is going to be Alzheimer's. So whenever your doctor, generally speaking, whenever your healthcare provider is telling you that you have dementia, in most cases, they mean you have Alzheimer's. Because when it's a different type of dementia, we're generally very clear that this is a different type of dementia. So I'd like to address that first. Now, dementia basically means that there is a change in memory and or another type of function that leads the person to be that impacts the person to the degree that they are no longer able to do things that they used to do by themselves. Okay, so you have to have 2 things that occur. There has to be a change in memory. It can be a change in memory, a change in language, your ability to communicate, a change in your ability to make decisions. So it has to be a change over here that leads the person to not to be able to be independent over here. Let me give you an example. The person starts to have problems with their memory, so they forget that they have to pay their bills. The person has a problems with their memory, so they forget how to manage their medications. The person has a problem with their ability to communicate, their language. So when they talk to you, it's like they're talking in gibberish. Like it's, I'm not being funny, but it's almost like you're talking to a baby. Like they can't get the words out. So they have significant word finding. They can't get the words out. They can't express themselves. Now, this is different than the garden variety of, Dr. Carrol, I can't remember that word to save my life. That can happen as you get older. But if it starts to significantly impact your ability to communicate, then we get worried that this is something bigger than what we would expect of normal aging. So the person has a problem with their ability to manage their house. You used to go over to grandmother's house and it used to be immaculately clean. All the clothes were washed, and then you go over to her house and things are in disarray. She can't find anything. She can't really remember how to use the washing machine versus the dryer. Cooking is becoming more complex. You may still eat over a house, but the food may not be done like it used to, or things of that nature. And so we worry about memory. No doubt, as we get older, we worry about memory. But it doesn't become a concern of dementia. It doesn't become a concern that we're worried about dementia until it impacts your ability to be independent. Okay. Now, if driving your car, they might still know how to physically drive a car, but they may get lost going to a routine place. They may know to turn on the blinker to make a left, but they may think they're going to church and end up at Home Depot, just using it as an example, okay? So we have to think about how is the person's level of independence is being impacted, okay? So often you'll hear people say, well, Dr. Carrol, I'm still independent, but it's just mighty, inconvenient. No, I feel like I can't remember anything, and I try to be as simple as possible by saying, what's the impact of your memory loss? Is it just frustrating because you can't find your keys? When you do find your keys, where are they? Oh, I just put them in the wrong purse. Wrong purse. That's different than you can't find your keys and your spouse finds the keys in the freezer of the house. That's something that happened actually this week for a patient. So yes, it can be frustrating and you can't find your keys, you put it in the wrong place, but it's important for us to discuss where is it eventually found. And is that what would make you think that would be the proper place? And so we start thinking of, sometimes patients and families will laugh when I'm talking about these extreme examples because they feel like, oh no, that's not my mama, no. And then 2 years later, they're like, you know what? She did something very similar to that. And so what that tells us is this condition is slowly progressive and it literally impacts the person's memory, thinking, their processing, even understanding what they see. Okay. There are 5 areas that can be impacted by dementia. 5 areas. The one that we spend the most time talking about is learning and memory. That's the biggest one, because that's the one that appears to be the most debilitating to you and I. Because a lot of people have always been told they have the best memory in the world. I can remember everything. I got a visual memory. I knew all my cousins' names. I knew all the street names were. So that's the part that's usually first noticeable by the patient and family. But that's only one of the 5 areas that can be impacted by dementia. Actually, up until I'll say about 8 or 9 years ago, often in order to make the diagnosis of dementia, you would have to have a problem with learning and memory. We weren't as concerned about the other 4 areas, but now we're realizing there are so many cases of dementia that's likely slid through the cracks because they didn't have the problem with learning and memory, but they were literally a different person. Mm-hmm. So learning and memory is what people talk about the most, like being able to remember stuff, remembering your PIN number, remembering when you were born, remember the birthdays of everybody at the church, all that type of stuff, right? But that's only one. Another domain, so learning and memory is one, executive functioning is one, that's big. So executive functioning is like your ability to manage the bills in the house, coordinating things, planning, organizing, putting things together. Now, we know not everybody's a trip planner. So I'm not expecting you to say, well, Sharon, you can't put together a trip for everybody in that. That's not what we're worried about. But we're talking about the person that used to have all their bills paid immediately. There was going to be no delay. There was no concern for bounce checks. There was no concerns for things being mismanaged. So those people, while they may remember things, they may come up to you and you may be confused, like, well, she can remember everybody's birthday in this room, but her taxes are behind. Her bills aren't paid, and it's not because she doesn't have the money. It's just that she is just disorganized. So that she's just very disorganized. So learning and memory, executive functioning. A third one is called, which is my favorite, because it's the most clear to me. It's called social cognition. Okay. So what do you think social cognition means?
Being able to get along with other people.
Right. What do you think social cognition means?
Oh, me?
Uh-huh.
That and, well, I'm gonna go from Aunt Lorraine. No filters, you just say whatever you wanna say.
Exactly. So what we see about social cognition, think about personality. Like this person all of a sudden is rude, they're a different person, they're coming to church and they haven't wearing something that's pretty inappropriate for church. They have no awareness of how what they're saying may impact those around them, and this is something that's different. It's like, oh, she would never talk, she would never say anything like that. So social cognition is sort of like knowing what's appropriate, the filter or being disinhibited, or, I told her we're going to church and she came outside with a bathing suit on. So and you laugh.
Yeah.
And didn't I say that earlier? I was like, patients and families always come and they like, oh no, that ain't my people. And then like 6 months later, they like, did you talk about coming outside with a bathing suit? So that's what you have to keep in mind. So social cognition is just like your general awareness of what's going on around you.
Out of character.
It's out of character. Right. And so you may say, oh, and then sometimes people say, oh, mom's just getting older and she wanted to change. Like, your mom wouldn't do that 30 years ago. Like, so we gotta stop issuing these excuses. And I say, the only reason why I say that is because when we issue these excuses and we try to protect our family members, it ends up hurting us in the long run when we don't have an open and honest conversation about what's going on, okay? So learning and memory, executive functioning, social cognition. The next one is language. So language is the one I said is your ability to communicate. So language can be impacted. In fact, some of the cases of dementia that's now getting a lot of attention, they have the part that's impacted is their language. There are 3 types of language things that we worry about. Expressive language, so talking, getting your words out, receptive language, understanding what the person is saying, and then grammar and syntax, and so how you put a sentence together. Like, that's the whole part. Like, they're saying English words, but it's just not, it's not put together right. And she used to be a teacher, so I know she can put together a sentence. So, your ability to communicate is impacted. Now, this is getting a lot of attention now, because Bruce Willis has frontal temporal dementia. So I'm pretty sure, I know where this is here, but when he was seen, the conversation wasn't necessarily this person has dementia. It was very clear, you have frontal temporal dementia. And as I mentioned, generally speaking, when the doctor tells you have dementia, in most cases you have what type of dementia? Alzheimer's. But we really have to be very clear if we think it's a different type of dementia. So when Bruce Willis left office, they told him he had frontal temporal dementia because his memory wasn't the issue. It was his ability to communicate. Okay, so that's the type of dementia that generally impacts language first. So memory's intact, able to tell you everything, but they can't put the sentence together at all. Okay, so that's the problem you have now. They also say Wendy Williams have frontal temporal dementia. I think that's still up for debate, but it's getting a lot of attention now because it impacts language first. And so some people feel like frontal temporal dementia is the most debilitating form because it literally strips the person of things very quickly. Alzheimer's, which is the most common form of dementia, is generally called the slow goodbye. So it's very, very slow, but the person's declining. The reason why it's important for us to talk about that, they decline so slowly that often the person that lives in the home with them, the person that sees them the most often, they will be in denial about what's changing because they feel like she's just getting older. What's the big deal? But when you look at the grand scheme of things, you're like, this is a completely different person. And the different person isn't because of something physical. It isn't because dad can't put out the trash anymore, like physically take it out. It's that he doesn't know what needs to be done to put it out. He doesn't know the schedule, not that the schedule can change, but he doesn't know that when we put the trash out, we take it to the side of the street. He just thinks it's just putting it outside. So it's thinking about those different things that change along the way. All right. So learning and memory, executive functioning, social cognition, language, and the last one is perceptual motor. Perceptual motor. So this one is a little complicated, and it really takes us to have a pretty good. You okay? It's all right. Come on in. It takes a lot for us to kind of understand what's going on from a perceptual motor standpoint. But the thing that I want, the best thing for us to consider when we're thinking about what is impacted in that domain is your understanding of what you see. Okay, So perceptual is what you see, what you understand. So they may see that this is a toothbrush, but they don't know what to do with it. Okay, so it's like understanding. So you may say, it's time to brush your teeth. They may pick it up, they may see you put toothpaste on it, but they don't know you're supposed to brush your teeth. Or someone seeing toothpaste and seeing the consistency of it and seeing that it's in the bathroom and thinking it's lotion. So they're taking a toothpaste, putting it in their hand, and they're trying to rub it in. So that's perceptual motor. So their understanding of what's going on. This is often, in most cases of dementia, that is impacted later on in the disease. Most cases. And often families will come to me and say, well, Dr. Carrol, you know what? I think, mom must be getting glaucoma or she may have cataracts, because it's like she can't see anything anymore, right? And it's not that she can't see. Her vision is actually fine. It's that she doesn't know what she sees anymore. It's the processing of it. Okay, so it's the processing of what the person is seeing. Like they actually can see, but they don't know what it is. So if you tell them to go in there and get a paper towel, and they go in there and they don't bring it back, they're like, she can't. Oh, like she can't. And she doesn't know what she's seeing. Right, so it's perceptual motor. And so that's that. So the 5 domains, the 5 areas of thinking. The 5 areas of thinking that can be impacted by dementia is learning and memory. That's the most common one that people want to talk about. So we're going to spend the majority of time talking about that one. Executive functioning, that's completing a task from start to finish, putting things together, paying your bills, organizing your medications, putting together the family reunion that you did every summer. Executive functioning. Social cognition, that's my favorite. My favorite is frontal temporal dementia. I love talking about frontal temporal dementia because it's just different. And I can smell frontal temporal dementia when I walk in the room, right? Because it's fun. It's fun. And I'm not saying I love what I do, but it's different because a lot of them have a lot of behavioral conditions. And I think that because I'm really interested in caregiver stress, I see the benefit in talking with those caregivers because the patients are generally younger, they're having more problems with language, and they can have a lot of behavioral concerns very early in the process, and we can help them a lot at the beginning. So I like the ability to help a lot with that one. So social cognition, language, which is speaking, understanding, and putting sentences together. And then the last one is perceptual motor. Okay. All right, now, types of dementia. That's always something to talk about. So, as I mentioned already before, Alzheimer's is the most common form of dementia. They are not 2 separate things. Think of dementia as a last name. Think of dementia as a last name. The whole family is called dementia. The last name is dementia, but everybody got a first name. So Alzheimer's, that's the big brother. Most of the people go have Alzheimer's. But Alzheimer's got some other siblings now. Okay. They have vascular dementia. That's his little sister that has strokes. So she had a stroke that impacted her memory and thinking. They have frontal temporal dementia. That's the one with the behavior, so they can't speak. They have Parkinson's dementia. So Parkinson's dementia happens in patients that have had Parkinson's for years. So they have Parkinson's first, and then later on they develop dementia. So they like married into the family. So we call them Parkinson's dementia. Then Lewy body dementia, that's another form of dementia. It's very similar to Parkinson's, but they haven't had those shakes and stuff for years. They had all of a sudden the shakes and the tremors and the hallucinations, it started in January, and then by June, they also had problems with memory. Okay, so that's a difference between Parkinson's and Lewy body dementia. They may look the same, but if they had Parkinson's for years, I mean, in their 50s, they had a tremor. And then in their 70s, they start having problems with their memory, that's Parkinson's, which was first, dementia. But if they start having tremors, and then within 6 months, they also start having problems with their memory, that's Lewy body dementia. Okay, so that's why it's important for us to be open and honest when we talking to our doctors about what's going on in the house. Trust me, we not trying to get in y'all business, but we need you to be open and honest about what has changed, when did we notice the changes, what's abnormal, what was normal for mom, what was normal for dad, because we often see that when we're talking to family members, there's a certain degree of being protected. I respect that. I don't want nobody knowing what's going on in my house, right?
Right.
I get that 100%, but if we don't open up at the right time, we will not be able to understand what's going on, so I can't counsel you about what can change. Okay? All right, now, all right, so that's Lewy body dementia versus Parkinson's dementia. Another form of dementia is mixed dementia. That's sort of falling out of favor, like we can't even bill for it anymore. But basically what mixed dementia is they sort of have a mixture of two different types. Like some of the stuff make you think that it could be vascular because a lot of it happened right after a stroke. But then when you talk to the family, they're like, well, she's been having problems with her memory for a while. So she might have had Alzheimer's too, but it was made worse when she had a stroke. So we used to call that mixed dementia. So they may have a mixture of one or two. Okay. All right. Actually, if you can ask about they have questions about the types of dementia, because I probably should address that. Okay. Anybody have questions about the different types of dementia? Because that's often one of the biggest things. Go ahead, sir.
Can you spell that, the one that's Louis, Louis something?
So Lewy body dementia is LEWY BODY dementia, DEMENTIA.
Thank you.
I have a question. So with the Lewy body dementia, if the person still never has the tremors between Parkinson's and Lewy body, then like, what is that? I mean, because it's like my mom has supposedly Lewy body dementia, but there is still no real tremors.
Okay, so you don't necessarily have to have tremors to have Lewy body dementia. So it's kind of nuance there. So sometimes they can present, and I'm not asking specifically about your mom's case, but they can present with severe hallucinations. They can start reporting they're seeing little kids running around the house. So sometimes the hallucinations are the very prominent symptom of Lewy body dementia. They don't necessarily have to have tremors, but when they do a certain type of imaging, it will look very similar to what they see in patients that have Parkinson's for years.
Okay, yeah, she has a hallucination.
Yeah, so often people will say, hallucinations are very, very vivid earlier in the condition. Hallucinations are most commonly as a part of advanced Alzheimer's. So as the person gets more moderate to severe Alzheimer's, they'll start having hallucinations. But when the hallucinations are prominent at the beginning, we worry about Lewy body dementia. They'll report, they see little kids running around or little horses and stuff like that, and they'll say it's most likely Lewy body dementia.
What about like other people in the house and things like that?
So that's fairly common as well. So that can happen at any step along the process, regardless of whatever type of dementia. The only reason why it's important for us to get as much history at the beginning as possible is because it helps us understand the type of dementia. As it progresses and it's more moderate to severe, it doesn't really matter what type it is, but it's good if we knew at the beginning because it helps us determine what medications we may be able to use. Okay, so patients can start to have hallucinations and delusions. Does anybody know the difference between hallucinations and delusions?
You did that.
Okay. Alright. So, no, the reason why I say that is because sometimes it's all about having a conversation about what's going on, right? So hallucinations involve the senses. That's the easiest way for me to describe it. So anything having to do with your senses, that's hallucinations. So they can hear things, they can see things, they can taste things, they can feel things. Feeling is very rare and most commonly associated with alcohol use, but they can have some, tactile hallucinations too, or tasting things. So you may think, they say, regardless of what they eat, it tastes like silver, or it tastes like they're eating a piece of coin. So hallucinations involve the senses. So it's hearing things, seeing things, touching, feeling things, tasting things, things like that, right? Right, smelling things. Delusions, they are a fixed belief that do not involve the senses, but you cannot convince them that it's not true. Okay? So a delusion is, oh, my cousin or my sister lives next door to us. Or it's a man in that closet over there. And you saw him? No, but I know you live in there. It's a man living there. So it's a fixed belief that you can't forget. And it's a lot of different types of delusions. A lot of delusions can involve money. You took my money. A lot of delusions can involve infidelity. There can be a lot of delusions that do not involve the senses. So they're not gonna tell you they saw the person. They're not gonna tell you they heard them. It's just that they're convinced.
Hiding things.
They're convinced that you're hiding it from them. It's just a belief. That's a delusion. Paranoia can be a lot of different things, but it's like, thinking things that happen, or thinking someone is coming to the home to harm them, or being afraid of you, things of that nature. Okay?
Can you have both,
Can you have both what?
hallucination and delusion?
Yes.
And does that mean it's severe or?
Doesn't necessarily mean it's severe. It'll just be we'll just have to talk about kind of what is the impact of those hallucinations and delusions. There are medications for everything, okay, except wandering. Let's be very clear. There's no medication for wandering. But there's a way we can classify the degree of the hallucination and delusion to determine if we need a medication. Okay, because believe it or not, some delusions and some hallucinations are comforting for patients. It's frustrating to us because we know that's not true, but it's comforting to them. So when I have a patient, actually a patient I see quite often, it was hard for me to convince the family that grandmother's willingness or her constant want to sit with her friend in her bedroom and talk to her all day was okay. Now that you might say, Dr. Carrol, what you told them to let grandmama sit all day? But what happens is the patient gets up every day, she goes about her day, and then when she gets frustrated with not being able to do something in the house, she goes to the room and sits in her rocking chair and talks to her friend, who is actually a mirror. So as she's rocking, she sees her friend in the mirror rocking, and they talk. And they catch up, and she tell them that my daughter won't let me do nothing in the house, but it's okay. And she is comforted by that belief. There is no need for me to treat that. It's not harming nobody. It's harming us because we she in there talking to that mirror. But that is comforting to her. It calms her down. Now, the flip end of that, I have some patients that we have to either remove the mirrors or cover the mirrors in the house. Because they're in the mirror in the bathroom and they look and they see that they're naked because they're getting ready to get in the bath, and they think that that person is watching them. So they're like, stop watching me. The man punches the mirror because he's like, why are you in here? So that person, you laugh. What I tell you about that? It can happen. It happens all the time, right? And so, and I get why you laugh, because you're like, this is so far out there. But the thing is, I think it's important for us to realize how powerful the mind is. Like the mind is powerful, and I can talk to y'all stories for days about stuff that's just like, I would never believe that this happened. And it just shows literally how the person's mind is unraveling. It's very sad, but we have to be able to understand that it's not the person's disease.
Right.
And that we are trying to work with this person to allow them to be as safe as possible. That's all it goes back to, safety. That's all it goes back to, okay?
I
All
have
right.
a question.
Okay.
Can you, two things on paranoia first? Is that, what percentage of, is it a fairly large percent of sufferers that have paranoia or, smaller percent? And also, can you redefine it for it?
Okay, so I would probably say, so in most cases of moderate dementia, I would say about 50% of the patients will experience some degree of paranoia.
Wow.
Okay, and a lot of times the paranoia is associated with the person's inability or difficulty accepting their own decline. So I have had to assume responsibility of mom and dad's finances. And so although I'm paying the bills, mom and dad, they don't control the money anymore. So they're like, what you doing with my money?
Right.
Like, I know you're doing something with my money, things of that nature, right? So I would say about half of them will experience some degree of that as it relates to their independence. Okay? There are three things that are, so you said define paranoia. So defining paranoia would essentially be, just the person's intense fixed belief that something is occurring and fear that they may be getting taken advantage of or being fearful of something. Okay,
Thank you, yeah.
no problem. So there are three things that we as adults, regardless of where we are, we think that those are the major three things that are linked to our ability to be independent. If we still can do these three things, we think we're independent. Name something you think that will be linked to your independence. Driving, that's one. Who was that?
Denise.
So Denise, if we ever have to stop you from driving, it's gonna be an issue, ain't it?
Yeah.
Okay, all right. So one thing that's intimately linked to your level of being independent is driving. What's something else?
Taking care of your business.
Taking care of what? What part of your business? Your money, because that's your money, right? You work hard for it. You work for the man for 50 years,
Yes.
and ain't nobody else gonna take care of your money like who?
You are.
Exactly. So finance was driving. Denise said driving. That's intimately linked to our ability to be independent. Finances. What's the third one?
Cooking.
Not as much. Sometimes people are willing to let go of cooking because they feel like somebody's working for them.
So maybe going to work?
Taking care of yourself.
Taking care of yourself, yes, that can be associated with a degree of pride. But sometimes people are okay with people helping with that. There's one more thing.
Bathing.
That's sort of like taking care of yourself. So this may be a little hard.
Being at their home.
Who is that?
Wendy.
Wendy.
My baby.
Wendy. So the last one is staying at home. Because this right here, this is my house. So you might take care of my finances. You might done stop me from driving. But what you're not gonna do,
For real.
take me out of my house, right? I ain't leaving my house. So I'm just gonna be right here. So y'all do whatever y'all wanna do around me. But this is my house and I'm gonna stay here. So whenever we have to have a serious conversation about those three things, driving earlier on in the process of diagnosis of dementia, managing finances very early in the process of managing dementia, leaving the house is toward the end, depending on what the care needs are, but that's always a fight. Okay? So often, as I was brought that up, sir, is that's when paranoia becomes more of an issue too. So when those things are challenged, because you feel like I can do this on my own. So if I can take care of my money, why you gotta take care of it? And what you doing with it once you take it from me? Things like that. Okay. All right. So that's that. So Wendy, you get a prize today now, because you done said it. All right. All right.
Yeah, they push back.
Say it again.
They do push back. They do.
They will.
Mommy did for a long time.
But as I always tell caregivers, wouldn't you push back too?
I do.
You
She's here.
would.
You would if you were.
You would.
Yeah,
You would.
I
You
would too.
because-
I
You
would.
would too, because you've been doing it yourself for how long?
Forever.
Exactly. So who is this person gonna come in that you raised?
Woo.
How are
Lord
they
have
gonna come in
mercy.
and start taking care of your finances?
Yeah.
Exactly. All right. Now, So I'll talk about different types of dementia. So let's talk about staging. Staging of dementia. So there's a lot of different ways to stage dementia. There's a lot of different ways to stage dementia. Staging dementia is, in most cases, when we came up with the staging criteria for dementia, it was for Alzheimer's. Okay, that's what most of the people have. But technically, everybody can have a stage, regardless of what their type of dementia they have. It just may not fit as neatly into it because it's really based on Alzheimer's, but everybody does have a stage. So I think the easiest way to talk about staging dementia is mild, moderate, yes, but severe is so much later that we generally say moderately severe. So a midway between moderate and severe. So mild, moderate, moderately severe, and severe. Now, mild basically means the patient needs help with hands-off care. Hands-off care is like they need somebody else to manage their medications. They need somebody to manage their finances. They need somebody to cook because things are going wrong. They need somebody to drive for them because they may have getting lost. So hands off. It does not involve the person's personal body, right? So we're just doing that work for them. That's mild dementia. There's some variation there. We can get into what it may look different, but generally speaking, that's mild dementia. Moderate dementia, they start to need hands-on support. Moderate dementia basically means they need someone to pick the clothes out for them. If you don't pick out the clothes, they may put on what they had on yesterday. If you don't pick out the clothes, they may put on something that's inappropriate. They know we're going to church, but they put on a bathing suit. They know that we're at a funeral, but they're laughing at the funeral. So that's moderate. Hands-on support. Okay? What's mild, sir?
Hands off,
Hands off like what?
driving,
Uh-huh.
taking care of their fields.
Take care of the pills, things like that. So that's mild, right? Moderate, they start needing hands-on support. Hands-on support, that's moderate. Moderately severe is still hands-on, but it's more of it. They may need help bathing. They may need help dressing. They may need help and physically needing help dressing. Not that they had a stroke, so they can't put their left hand into their jacket. It's that they don't know that they need to put a jacket on. Okay? All right, so that's moderately severe. So moderately severe, which is the most, it's associated with the most caregiver stress. Moderately severe is because the person's still ambulatory, they still can walk around, but we don't know what they're gonna get into. So it's like we gotta take care of a baby in the house, right? So they may need help with bathing, dressing, problems with number one, problems with number two. So it's like we're doing a lot for the person. So that's moderately severe. Then severe is when you start having problems with language, significant problems with language. The reason why I said there's gonna be some variations, because keep in mind, if you have that type of dementia, frontal temporal dementia, like Bruce Willis, your language may be impacted earlier. So when I see patients that have frontal temporal dementia, the family sort of, gets very frustrated and they freak out because they're like, Dad can't talk anymore. So you're telling me he's already in the severe stages. Well, no, when we think of staging, we're thinking about Alzheimer's. So they have that part of it, but he still can bathe himself, he still can dress himself, so he's not that far advanced. Does that make sense?
Yes.
Okay, all right. But when you think of Alzheimer's, which is how we stage most dementias, the severe stage, the beginning of the severe stage means they say about 7 words a day. Clearly. Other than that, they're quiet. Okay? And that can be frustrating to families because, and when they were in a moderately severe stage, Mama wouldn't stop talking. She wouldn't stop telling you that she going to work tomorrow. She wouldn't stop telling you that I run this house. And now all of a sudden you get the severe stage and mom just sitting. She's doing nothing, right? So family's like, what just happened? Did somebody turn the light switch off? And that's just progression of the disease. Okay.
Dr. Carroll, I'm sorry. Can you repeat what you said in the beginning of severe? You said.
Okay.
Okay, I'm sorry.
So it's all good, it's all good. So for severe dementia, one of the hallmarks of severe dementia is your language domain starts being impacted.
Okay.
Your ability to communicate your needs. So it's almost like you playing charades with the person because you don't know what they talk about, you don't know if they're hungry and all that type of stuff.
Okay.
So it's language. But did you hear the part about frontal temporal dementia?
I did.
Okay.
So I heard you say, about 7 words you can understand clearly, and then I guess.
What I was saying about that is there's a type of dementia that impacts language at the beginning.
Yeah.
It doesn't necessarily mean that they jump from mild all the way to severe.
Okay.
That's what I was saying.
But in Alzheimer's dementia, you said.
Right,
severe.
but if they've been diagnosed with having Alzheimer's dementia, when
Yes,
they
that's
start
mommy.
having problems with language and they speak less than 7 or less words a day, then
Yeah.
that's severe.
Okay. Okay. So I think that's where we're at. That's
Okay.
why it piqued my interest.
Okay, that's fair. And then other things that can be impacted in severe, it starts by impacting language, then it starts impacting the person's ability to do other tasks like walking.
Yeah.
Now you may think, what do you mean they can't walk anymore? It's not that they don't have, their legs don't move, it's just they can't coordinate it. So they may stand up and they may step with their right, but their mind isn't, their mind doesn't tell them that the next step is what? Right, so they'll
Right.
just,
Correct. Okay. Okay.
like they can't coordinate it.
Okay.
Okay,
That's how they have you.
That's clearly where we're at. Okay.
Doctor's office, right?
Okay.
they probably want to evaluate perceptual motor, one of the domains, but yeah.
Okay,
So we would know if you're to this degree, but yes, that is one reason why, yes.
okay.
Uh-huh.
Thank
So
you.
yeah, so they'll start having problems with ambulation. They'll
Yeah.
start having,
The mic's everywhere.
okay, sorry. They'll start having problems coordinating walking. They'll start having problems managing their muscles so they can sit up straight. So patients with severe dementia, they can rarely, severe dementia to this degree, it's various parts of severe dementia. They may not be able to sit in a chair like this because they're not managing their muscles of their back anymore. They don't have any control of them. So they would have to sit in a chair with arms, or otherwise they will go this way, that way, or that way. Okay, so they can't do that. Severe dementia, they lose their ability to smile, so the muscles here, they can't control it. And so that just shows you how it can look at the severe stages. So think of what has changed over time. We went from somebody who was running the house, help raise their kids, raising their grandkids, then they started having problems remembering to pay their bills. Then they started having problems picking out the clothes. Then they started having problems needing help with bathing. And now we're at a point where they can't even sit in a chair.
Mhm.
So dementia is more than just memory loss. It impacts every part of the person's experience and their family. And I think it was 2 more questions for you. I think you had a question.
I was asking, are we at severe now or is going into severe?
We're at severe.
Um,
So at the beginning of severe is when you start having impact on language. The end of moderately severe, they can't manage number 2 on their own anymore. And it's not that I gotta go, but I don't get there in time. It's that I'm sitting here talking to you and it just happened. Okay, so that's moderately severe. Okay. Now, it's a couple more questions.
So if a person has like the Parkinson Lewy body dementia though, would that affect their ability as far as walking prior to the severe stage? Okay, so that just all depends on the situation. Okay.
Yeah, so, but when we came up with the staging system, it was for Alzheimer's, right?
Okay.
But we still use the staging, and so I would say, this person is, I would say this person is fast 6D, which means that they have, and FAST is how we communicate with, that's how doctors communicate, right? So we'll say this person is FAST 6D with Parkinson's dementia. So that person will probably have problems making it to the bathroom for number one. They're good with number two, but they have Parkinson's, so we expect they'll have some they'll have some tremors too. It's not the tremors that we may see later in Alzheimer's, but we just have to, that's the context of it.
Okay.
Does that make sense? Okay. Sir, you have a question?
I'm okay, it got addressed, thank you.
Okay.
Hereditary?
Which one? Alzheimer's? So yeah, so there are some forms of Alzheimer's that are found in the genes. Okay, but it's very, 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 very rare for those forms to rear its head at 65 and after. Most cases of the familial Alzheimer's disease, the person starts having problems much earlier than 65. They'll have problems in their 40s. The youngest case of dementia I've ever seen was someone who was 43. And it was very, very advanced already, but they haven't had problems for about 5 or 6 years. And they had the familiar form. So it can happen, it can be passed down in the genes, it's very, very rare. Most cases that we see, patients 70, 75, 80, it's not the genetic type. Okay. All right. Go ahead.
Is the genetic type the one where it's discovered really early in the 40s?
So, yeah, so the genetic type is in the genes.
Yeah.
And the penetrance is very high. What does that mean? If it's in the genes, it penetrates very deeply. And so it expresses earlier. So you may say, my grandmother had it, and come to find out, all her brothers and sisters had it too. They got it in their 50s. Then my mama and her brothers and sisters, they got it in their 40s. And here I am, 35, and I'm having problems with my memory. So the penetrance is high. So most people in the family are gonna have it. Now you may say, well, Dr. Carrol, you must be telling me my family we must have got a genetic form because all my grandma and sisters got it too. Most likely, if it was diagnosed later in life, it's just that they all end up having Alzheimer's or they all have vascular dementia, which is the fastest growing form of dementia. Vascular dementia is the fastest growing form of dementia. Alzheimer's is still big brother. Most people have Alzheimer's. But why do you think vascular dementia is the most common, most fastest growing, Mr. Stan?
I'm recalling.
Folks.
Well, it deals with stroke, right?
It deals with stroke, exactly. So the reason why vascular dementia is the fastest growing form of dementia is because we are not controlling our stroke risk.
High blood pressure.
Our high blood pressure. What else besides high blood pressure? Diabetes, cholesterol. So if we're not doing our part, and all of us going to grandmama's house to eat Christmas and where we going tomorrow for Easter? Right. Easter, Mother's Day, Christmas, Thanksgiving, we just eating it up. And there's nothing wrong with good food. I'm from the South, trust me. It's nothing wrong with good food, right? But we gotta balance it. We gotta take care of ourselves. And when your doctors say, yeah, you eating all that good food, you need to diet, you need to exercise, the biggest thing is portion control. It's how much of what we eat. We're not saying you gotta completely cut it out, but you can't be going back to third, second, and thirds all the time. Okay? Diet and exercise is key.
You
All
have
right.
a hand online. How do you want to have a question?
That's fine. You can do it.
Okay, go ahead, Denise.
Thank you, Dr. Carroll. Just invaluable information. I guess because I'm dealing with two individuals that in my mind have done everything that has been said and researched to prevent. One person did have a family history of mother, sister experiencing dementia. The other person, I'm not sure, but it just leads me to believe that there's not really any prevention of this disease.
Yeah, I mean, I think we're still working on that a lot. I mean, I still think the best thing is diet, exercise, low stress. I added that in because I think I see a lot of patients that are extremely stressed and they just literally lose their mind along the way. I'm not speaking lightly about that, but I think diet, exercise, low stress, activity and engagement. So the reason why that's important is because we go through life and we work for the man for 40 years. And when we retire, we don't want nobody telling us what to do, when to do it, how long to do it, when to wake up, when not wake up. But that job that we had for 40 years, it might have been stressful, but it gave us a routine to our day. It told us when to wake up. It told us we need to go to bed because I need to be rested for work tomorrow. It told us when, depending on what kind of job you had, it might tell you when you go to the bathroom and when you eat, right? But when we lose that with retirement and we veg out, we don't do anything else, we essentially don't use our mind anymore. So we have to be engaged. We have to do things to enrich our minds and continue to challenge us. We have to do that. And the last one that I say is don't sleep on sleep.
What is that?
Do not sleep on sleep, meaning you need to make sure you sleep.
Enough?
Yes, yes. Right. I did a community lecture one time saying, don't sleep on sleep. Like, that's how I talk. But don't forget how important sleep is. Because we be, busy, only sleeping 4 or 5 hours, that's not good, over time. You at least need to sleep 6 hours a night. It needs to be more than that, but at least 6 hours a night. Okay? So diet, exercise, low stress, activity and engagement, and sleep.
Thank you, Dr. Carroll. And I think the people that I'm considering is the amount of stress that they endured and being so laser focused on what they were doing in terms of their lifestyle. So those were two things so thank you.
Anytime. And there was another hand. Okay. Any questions?
Hi.
I have a question.
Okay, Lindsay, we'll come to you next.
Oh, sure. No.
And you'll be next. Okay.
Oh, thank you.
You have, was told vascular and all 5 of the domains that you said. And I've experienced, and also he's at the severe stage. So what else are we going to expect?
Okay. So if he has if your husband has vascular dementia and he's at a severe stage, so it's impacting his language, the ability to communicate.
Correct.
Now, not to get too specific about his case and his personal information, but was his language impacted because of the stroke?
Actually, no.
Okay, because that can happen too. You can have a stroke that impacts your ability to communicate, but that doesn't necessarily mean you're sick. Okay. So what do we expect in the severe stages? So in the mild stages and moderate stages, generally speaking, it's more emotionally draining. Generally speaking, it's more physically draining because you're having to do so much for them, right? You gotta fight with dad about driving. You gotta fight with him about taking over the finances. But when it gets more severe, it's physical and emotional because you feel like this person that you married, that you're committed to your whole life has changed. And so generally speaking, when patients get to the severe stages, may have problems with language, still able to walk? Is he still able to walk?
A little. He
Okay.
had another stroke. So
Okay. So it starts to be, your world appears to get smaller because they're not ambulatory as much, they're not walking around as much. So they're spending more time in the bed. What we worry about when they get to that point is things like bed sores. So making sure care is appropriate there, because keep in mind, dementia is a problem with signaling. So don't think about it as just memory. It's signals from your brain going to your body telling you what to do. So just like you shaking your head, okay, like that, your brain told you, acknowledge that you listened, that you hear, like, okay, whatever. So they lose that ability. So one of the things they can lose is their ability. There's a signal that goes from your brain to your body telling you to turn over in the middle of the night. So if we lay in the same spot all night, we'll have the beginning of a bed sore in the morning because you laying there for like 8 hours. You will toss. That's what tossing and turning is. Well, we think tossing and turning, we like, I can't sleep well at night, but your body automatically tells you need to turn over because you don't need to develop a bed sore. That's your body's natural response to laying down. So you turning over, you stretching your leg out, that's your body saying, okay, we can't be in the same spot too long, right? But they lose that ability. So they will literally stay where they are, wherever you put them. and then that can lead to a bed sore. So when we worry about the severe stages, we worry about that signaling problem, so them being in the bed. We worry about their eating, because swallowing itself is a very complex process. You don't realize how complex it is, but they start to swallow and things go into their lungs instead of their stomach, that causes an infection. So they're not eating well, and if you're not eating well, your skin becomes thinner, because it's a lot of nutrition, the nutrition helps your skin be thin, and then you have problems like that. That's sort of what it looks like. You know, we start to see they need more hands-on support, they need more focus, someone has to turn them, because they can't turn themselves.
Wendy?
Okay, so, I've noticed this quite some time ago, and I've also mentioned to my Jeannie, mommy like shakes. And I asked her, I said, well, can you develop Parkinson's after dementia? But she does, her right, she does, her right hand shakes. And it's so, last Sunday, Kiki was holding mommy's hand to help walk her to the car. She says, Wendy, her hand is shaking. I said, you know, that happens. And I don't know why. Like last night, her arm, right, everything, it was just shaking, like really. And I watched it because I wanted to see if it was gonna stop or was she gonna make it stop or whatever. But it happens quite often, and I don't know if it's just happening or is she doing it. I don't know.
So the short answer to your question is, can you develop Parkinson's while you have dementia? The answer is yes.
Okay.
Because it will be a separate condition.
Okay.
But in most cases that doesn't happen. Generally speaking, we would expect a resting tremor with Parkinson's. And a resting tremor, they can't really turn it on or turn it off. The only way they're able to turn it in and turn it on and turn it off is if they hold their hands together. So sometimes when I see a patient and I'm concerned that they may have a tremor, if I see that it's like you can see me, right?
Yeah.
I see that they're sitting in front of me like this, it's because they're trying to control it, right?
Okay.
But a resting tremor is they're sitting there, their hands are not together, and they're just like shaking. I don't know if you can see.
Okay. Yeah. That's what it.
That's a resting tremor. So
Okay.
most cases of Parkinson's disease will have a resting tremor. There's another type of tremor that's called an intention tremor. An intention tremor, it appears that you can turn it on and turn it off, but if you intend to do something, that's when the tremor becomes the issue. So I'm trying to get Kim's phone, so it starts shaking. But if I'm just fine by myself, I'm good. But if I'm trying to pick up a glass, it'll start shaking. That's an intention tremor. So I'm intending to do something. And then by the time I get there, it's shaking. So sometimes people will have intention tremors associated with drinking at the breakfast table or picking up their fork to eat or something like that.
Yeah. She doesn't. I'm sorry.
No, go ahead.
No. Okay, she doesn't intentionally do much, so, and that's why I'm just like kind of weirded out.
The other type of tremor that can develop in dementia could be the result of medications that are being used to manage the dementia. So that's the other thing.
Okay.
So we might be using a medication to manage a behavior or a mood change, and one of the potential side effects of that medication could be tremor.
Okay.
Depending on what medication, I'll be able to tell you if you tell what medication it's on, that it could be a side effect. Okay, because the thing is, we try to target certain behaviors and we use certain medications for a variety of reasons, and one of the potential side effects could be tremor. It just could happen.
Is it worth the side, does it vary, that's the question of, is it worth the side effect to still take the medication to help them to control the behavior?
In most cases, yes.
It is worth it.
In most cases, okay. But that's a conversation I have, and it's case by case basis. Because, we'll have a patient that'll develop a tremor after being on a medication for 2 years or so, and we've had to adjust it. But the reason why we're using the medication is because they were physically aggressive toward their caregivers.
Sure.
Or, they were having significant problems falling asleep. So I talked to the family, I said, you know, unfortunately, this is a potential side effect. And generally, we have that conversation at the beginning. You know, this could happen with using this medication, but these are the reasons why we're using the medication. Okay, and generally speaking, when we have to use those medications that can cause side effects, I try to avoid it as much as possible. But then we have to get into what is it called, what is the behavior that we're trying to target? How is it impacting the patient? How is it impacting the family? And then we have to participate in what we call shared decision making. So I tell you what the medication is, no, you tell me what's going on. I tell you what the medication we can use, and then we decide as a group, do we want to move forward with this medication, knowing that this can be a side effect.
What are some of the medications? What are some of the medications?
So the ones that come to mind immediately, they're antipsychotics.
Okay.
Okay, so those are medications that are used, that were initially developed for conditions like schizophrenia, bipolar disorder, you know, all these different types of conditions. And those medications, when they were first developed, they were just for those conditions. So when they were using those medications, they were using them, and they still use them. But when they first came out, they were using them at very high doses for long periods of time, because these people were seeing things, hearing things, you know, they're an 18-year-old person with schizophrenia, right? So they needed these medications, and sometimes they needed higher dosages. And so they start to develop these potential side effects. So later on, we started using those same medications for patients with dementia. Now, we use the same medications, but at very low doses. Okay? But because it's the same medication, the side effect can happen.
I was gonna see you, but I saw another doctor at Kaiser. She takes a pill twice a day. I forgot the name, a little gray pill.
Oh, I don't know the colors.
I'm
It might be a little bit of
gonna make an appointment with you, but you haven't seen her in years and years and years. I wouldn't want to diagnose.
We'll touch bases. Okay? All right.
Two questions online. So the first one was, what happens if the person sleeps and has a hard time staying awake?
Okay, all right, I forgot to answer one part of your question. So the one part of your question was the type. I think you said what medication. So it will be medications like Seroquel or quetiapine, risperidone or risperidone, Zyprexa,
None of those.
Abilify, aripiprazole.
Seroquel was the great deal. No, that's the one.
It could be, but
But your name of it again?
no, you can't cross color,
Okay,
you can't cross
okay.
color. The reason why, these are generic medications, so it's depending on where your hospital gets theirs from. So it might be blue at Kaiser, it might be gray at
It's
Cedars.
a generic.
Right, so don't go off the color.
Right.
And you be done told somebody, Dr. Carroll told us, it's great deal. That ain't true, Dr. Carroll, I feel like a great deal. It's a great deal. No, you always take great deals.
There's
Okay.
one, I'm trying to think of the name that mom told me day one. She said, oh no, she said, I'll lose my memory before I have headaches. And it's a very common medication. Can you kind of?
That causes headaches,
Yeah.
and it was for dementia?
Mm-hmm.
Okay, so
That's it.
So,
That's it.
and
That's
generally
it.
Aricept doesn't cause headache. Memantine or Namenda is known for headaches.
And Aricept was.
They tried to
That's
prescribe
what she
my
did,
mom
romantic.
Aricept.
Yeah, that's known for headaches. That's known for headaches.
Yeah,
Okay.
that's the
That's
one.
what I was-
Okay.
But I do wanna,
All
I
right,
do
so-
wanna make sure that we get to the question.
Yeah, that's fine. So the
first
one question was, if mom or dad sleeps too much, I'm sorry.
Yep.
You wanna, okay.
So the first thing I would probably say is, what's her level of activity? But when did this happen? Was it abrupt or has it been gradual? Like, did mom used to sleep 8 hours a day, then it became 9, then it became 10? Or if it's like 2 weeks ago, she was up moving around and all of a sudden she just bedbound and won't wake up. So if it's something that abrupt or that quickly, I would be concerned about a potential reversible cause, like an infection or something that's causing her to decline rather quickly. The second would be if it's medication induced. If mom or dad is still managing their own medications, which I doubt based on what you're describing, could they have taken too much or forgot to take a medication?
Mm.
Or if the medication we're using to manage the behaviors, one of the potential side effects is sleepiness. So when we adjusted it to address the behavior, are they sleeping more because of that?
And if you're giving them the medication, making sure you're giving them the right dose, because I
Exactly.
believe Brenda online had that experience where her mom was sleeping a lot, and then she learned that she was giving her too much
Exactly,
of one.
exactly. So
of one
sometimes, so I would say, we always want it to be reversible, right? So we want to see, is this an infection? Is this something that we can do? And a urinary infection, most common cause, or a skin infection if we spend a lot of time in the bed, so the skin can get very thin, or a pneumonia, or something like that, that we can treat that can potentially reverse some of it. Not that they go get back to where they were when you were 60, but we want to get them back to before things decline immediately or quickly.
Denise?
Yes, my question is regarding mental health and psychotropic medication. Has there been any research around someone with a mental health issue that's been on a antipsychotic that has helped not to have dementia, and then after they came off of it at a certain age, then they developed dementia? Any research around that or any theories on that?
So yes and no, there is a lot of research on psychiatric diagnoses, such as patients with schizophrenia, such as patients with bipolar disorder. Those patients are at increased risk of developing dementia. We do not know if it's the medications that they've been on for so long that causes it, or if it's a comment on the fact that their brain is functioning abnormally already because of the schizophrenia and bipolar disorder. So it takes less of a hit to cause them to develop dementia. Does that make sense?
Yes, yes, thank you.
And the reason why we think that could be the way, or that the reason why that theory makes sense is because there is a theory of what we call cognitive reserve. And so cognitive reserve means that this patient was very high functioning for a variety of reasons, where they could be educationally attained or just life experiences. They were on top of everything, right? And so this person was so high functioning that their brain was wired so tightly that they were able to compensate for a long period of time where people didn't know that things were starting to slip, right? So they have a lot of cognitive reserve, and so they're declining, but they got so much reserve, so much in their bank that you can't pick up on that, right? So they got so much cognitive reserve. The problem with patients with cognitive reserve is they are the most difficult patients to take care of.
Yes, yes,
Because
yes.
it's like they got a lot of reserve, a lot of reserve, a lot of reserve, a lot of reserve. They hit a wall, and all of a sudden it's like boom. And we think it's boom because this person was on top of everything, and then now they can't do anything. But things were falling down behind the scenes for so long, we just caught it at the last minute, and we're like, oh, this person ain't paid any taxes in six years. This, so they have this cognitive reserve. And so that's the same theory we use to kind of potentially what's happening with patients that have schizophrenia and bipolar. They've been taking these medications for so long, or the wiring in their brain is already abnormal, that it doesn't take much for them to sort of tip over to have dementia.
Thank you.
No problem, anytime.
Lori?
Yes, thank you for taking my question. So, listening to the different stages of moderate to, mild to moderately severe and severe, thinking of my particular family member who lives alone, and based on the definition, I mean, she can bathe herself and dress herself, and she teaches classes still, and she's very lucid in that space, but seems to not be lucid anywhere else, very, very, very forgetful, a minute to minute. Locks herself out. Somebody just gave her a car, which we were all horrified at. So she's driving and, leaves the stove on and all this. And she lives alone and she's fiercely independent. I think she's one of these cognitive reserve people you just spoke about, 100%. And so we're all concerned about how to keep her safe, how to keep her from having people come up there and take advantage of her. One of her tenants said, hey, let me buy my house that I live in from you. I can do that, and trying to make sure she doesn't sign paperwork and, things that we're just concerned that she would be taken advantage of. She does live alone. So based on the definition, she would be moderate. But I can tell you, we feel like it's more progressive than that. So how can we move it forward? She's not been to the doctor. We're trying to get her to go so she can be diagnosed. And she seems to be resistant to even going. So just not really sure how to move that needle forward for someone like that.
Okay, so based off what you're describing, listen to what you said, I would probably classify her as mild, to be honest. Because
Yes.
it seems like she needs hands-off care. So she
Yes.
needs someone to manage her finances. We don't know if she's cooking well. We don't know if she's doing her medication. So it's most likely mild. But you said she's able to dress herself, bathe herself, all that stuff on her own?
Oh, yes. Talks
Okay.
all day long, everything.
Right, so patients in the mild category, as I mentioned, it can be very emotionally and physically draining because the person lacks awareness of their deficits. So they don't know that they need help.
Mm.
They are unwilling to accept the help that they need because they think everything is perfect in here, right? So that can be very difficult, but that can also be a risk because I don't know if you were on, we were talking about the different domains, but it appears that the domain that's impacted with her is learning and memory and executive functioning. So her
Yes.
ability to complete a task or pay her bills. So you may find out she hadn't paid her taxes in a year or two. Like you may find out things are falling through the cracks. If she owns property, which is very common in Los Angeles, it'll be important for us to sort of find out what's going on with the properties because she could be taken advantage of. And that's because of executive functioning. That doesn't mean that it's moderate. It just means she can't handle the finances. She can't manage the properties that she has anymore.
Okay. Okay.
Like how you get her to the hospital and to the doctor, that's always a difficult one. There are some doctors that can come to the house. In most cases, that's through the Department of Elder Services with, Adult Protective Services. I'm not blaming you or anybody in the family that's what's going on, but sometimes that is a way for us to get into the home in order to see what's going on with the patient and potentially protect their assets.
Okay. You said Department of Elder Services, Adult Protective Services. Would we have to call them?
Lori, I can
Yes,
give you that
if you're
information.
concerned that she's neglecting her ability to be independent or she's self-neglect or neglecting because what I've seen happen before in cases like this is the tenants start to create issues and they refuse to pay rent. And so it creates this big thing where we're trying to figure out, can this person even manage the property anymore? Because they may not be addressing the needs of the owners, the tenants. And yes, some of that could be driven by the tenant just not wanting to pay, but then it sort of unravels if we as a family haven't stepped in to sort of see what this person is still able to do.
Lori,
My
I
other
can give you
question,
that information,
you can
Lori.
give me that. Okay. How does power of attorney play into any of this?
So power of attorney would play, depending on what type of power of attorney you have, but the power of attorney would play, but that still will require her to be evaluated. And someone to make a determination that she can't make decisions for herself, so we can activate those powers of attorney.
Okay, thank you.
Okay,
Thank
we
you,
had a situation with Aunt Lorraine, who really was our first cousin. Could not get her to get out the house. So the Lord worked it out where we were able to locate a forensic psychologist. That means he can go to court and testify as an expert. Now, his name is are they here locally in LA? Your relative?
Yes.
Yeah.
Okay. Call his doctor and see if he still make the house calls, because he did it. Because Aunt Lorraine's property was stolen by the 30-year-old tenant who got a crooked attorney to create a new trust that knocked us out. But I said, I need somebody who will make a house call. So he made the house call. Now this was about it's been longer than that. But anyway, then just get your checkbook out. It was $1,200, but it was worth it because he was able to assess Aunt Lorraine and make the case so strong, saying there's no way that she could have made these decisions.
Wow, that's awesome.
So, yeah, it was awesome. And then the, Lord help, then the doctor was crooked. That's a whole nother chapter in the book. But call this number, Dr. Gary Friedman Harvey. And his phone number is 562. I got two numbers, 493-2244. Then the other number is 562-209-4399.
Oh, thank you.
And tell him that Sharon from the San Pedro, he won't forget at Lorraine's place. He came on Gaffney and San Pedro and evaluated her at Lorraine. He's the one. And then that kicked out the tenant. Then, let me tell you, because I could have had it in jail, but we talking about the Easter season. So I will let the Lord use her and go on and try to forgive. But he's the one that can do it if he still make them house calls.
Oh, I thank you so much. Praise the Lord. Thank you, and thank
It's
you.
my pleasure. It's my pleasure. And he'll be have empathy for you because he told me that. He said, my heart goes out to you because I see it all the time.
Wow.
Do you have access to anybody in real estate title companies?
Yes, I do.
Have them run the property. Because my darling mother is the one that told me to call and check on Lorraine's property. I called the title company and then they told me there's been another deed. That's when I discovered that the deed had been changed and where the crooked attorney had put it in the tenant's name. And some of my legal friends, the judges and all of them said that would not happen, but they did. If you get a crooked attorney,
Wow.
they can do it. Then be sure to run the attorney through the LA bar, because that'll tell you if they got some dings on them. And Aunt Lorraine's, the attorney this tenant got, had already had dings on her. Then mother now hadn't gone fully out, bless her sweetheart, was coaching. Run, check the attorney out. Then you even maybe, if it ain't Dr. Carrol, check the doctor out. We checked and found out her doctor was crooked, so they was in cahoots. And you can run that with the medical board. But immediately get to you, whoever you know that can run the title and see if the title has been changed. Get the APN number off the property and make sure them taxes are paid. That's what you need to do.
I'm trying to write it down. Thank you, and thank you so much.
I have most of it. I wrote most of it.
We didn't wait for this for nothing.
Yeah. We have a question, Dr. Carrol.
Oh, I appreciate you. Thank you.
You're my pleasure.
Go ahead.
I have a question. Right now, my son is in Kaiser, been there since Tuesday. They called last night and said he was diagnosed with dementia. I've been trying to see you for over 2 months, but you have to go through neurology and then they don't okay for me to see you. So now that it has been processed or whatever at Kaiser, can I still try to make an appointment to see you, Dr. Carrol?
So that's actually a very difficult question.
Okay.
Technically, how old is your son?
64.
Okay, so technically I'll see patients beginning at 65.
That's what they told me.
So, all cases of dementia before the age of 65, they require a different level of, workup and evaluation. Not that we don't do the appropriate evaluation for a 70-year-old, but when patients are in their 40s and they get dementia, this is an example, they have to go through more testing to find out if it's the part that's in the genes and all that type of stuff before they get to me. I'll have to get your son's information and I'll find out what's going on. I'm unaware of it because it's literally a hard stop. If the person is less than 65, I can't see them.
I know, they told me that.
Yeah, so that's just how it is. So we'll talk.
Okay.
Can she make some noise and see you?
So this is the issue. when the noise has been made in the past, it created this huge thing.
Okay,
Because the thing is, once I see one 64-year-old,
Okay,
they
yeah.
want me to see a 63-year-old, they want me to see a 45-year-old, and I'm just gonna be destroyed.
Wait a minute.
Right.
I am a retired police officer.
But if nothing else, I'll see what's going on with neurology, we'll figure it out.
Okay, all right, thank you, Dr.
No problem.
Carroll.
Any other questions, go ahead, Mom. Oh.
Did you have anything else you want to share, Dr. Carroll? You have maybe about 5-6 more minutes.
Okay, so the part that I probably didn't get to, that I should, is the importance of taking care of yourself as a caregiver. So this is a caregiving, group, and I try to refer as many people to this group as possible. But the thing that you have to realize, you have to take care of yourself before you take care of your loved one. Often we want to fall on our sword and say, I did this for my husband, my wife, my mom, my dad, but then you neglect yourself along the way. So you're not taking care of your own medication because you want to make sure she's taking hers on time. You're not going to your own doctors because you want to make sure she's taking care of her doctor. And that's all fine and dandy, and that's amazing. I'm so happy for you. But if you're not taking care of yourself, something will happen to you, okay? The reason why it's important is Alzheimer's is the slow goodbye. So if you're not taking care of yourself physically, you're gonna be on the fast goodbye. And then if you on the fast goodbye and they the slow goodbye, who go bye first?
I am.
The fast goodbye, right? So you have to take care of yourself, okay? So I want to reinforce that, taking care of yourself. Also, please be open and honest with your doctors. Please be open and honest with your doctors. We often see spouses protecting their loved ones because it's like, oh, I do that too. Like, that's not a problem, I do that too, but both of y'all probably need help. And you really, peel back the layers, like, so you can't be afraid. So often we'll see spouses underreporting on their spouse. We'll see adult children over-reporting because they want to take over. So, yes, tell me everything you need to know, and then I'll figure out where I think the person is, and then we gotta work together as a group. Okay? All right, anything else?
Brenda?
Brenda, what you talking about?
You doing? So my aunt that you diagnosed, we've been working with her daughter, and she's moving her to East Bell in near Corona. And so I was wondering who would be your counterpart in the Riverside area that we could recommend to my cousin for my aunt to see.
Yeah, so there is a clinic in Riverside, because I actually met with them probably a couple months ago. But I don't know the name of the providers. I think it's two of them. One is neurology, one is geriatrics. I'll have to look into that information for you, but there is a clinic at Riverside. It's at Riverside Medical Center.
Okay. Are they part of Kaiser? Are they part of Kaiser?
Yes, it'll be at Riverside Medical Center.
Okay, thank you.
So they have an office too.
But they don't have you though.
No.
Then who is you at Riverside?
They are Carol.
Well, there's somebody that does what I do. That's all I can say. I'm not gonna rule them if they do what I do. Anything else?
So you get the information to Sharon and Jeannie and Kim?
Or what?
For the doctor that's
I'm not gonna be able to tell you is Dr. Kim. I'm not gonna, but there is an office there. That's the only thing I can confirm. And one of the things we've been doing is trying to make sure that the services and the access to a physician are equivalent across all medical centers. So we have 13 medical centers within our system. And so each medical center will have their own memory evaluation clinic. How they run it could be a little different, and who's in the clinic is definitely gonna be different. But there is a clinic there for you.
So her file that you started on her and everything, even though she's in the Riverside area, those doctors will be able to see all the extensive notes and stuff that you did on her.
Yes. So we are a closed system. So I can see all the records that they have on her, and they can see all the records that I have that I have on her as well.
Okay, thank you. Okay,
Anything else?
So Dr. Carroll, we want to thank you so much,
No problem.
so much. Every time I learn something new, I got amazing here, and I'm like, this is my fourth time here. Thank you so much for being here today and for being, part of the Acts family. I'm gonna stop this recording.